I'm Kjell Arne Johansson. I'm a professor at Bergen Centre for Ethics and Priority Setting in Health, BCEPS. I'm also a medical doctor at Haukeland University Hospital. This is a mini lecture about principles and criteria for priority setting in health. We have three important principles for priority setting in health, and all theories, everyone would agree they are relevant. Maximize health, priority to worst off, financial risk protection. What does it mean? Maximizing health is about finding the best buys. Imagine this is the population level, the small red square. It can be influenced by either giving more to health, you would increase the population health. But if you have good methods for identifying the most cost-effective interventions, you would have even a higher return to the investment. Disease control priorities is an important project for helping identifying best buys in low and low middle income countries, and it started with DCP1, Investing in Health report from 1993, and today DCP4 is being revised and updated and led by Ole Fridtjof Norheim. This is an example of rank ordering interventions according to the cost effectiveness. We have epilepsy interventions, antihypertensives and statins, and obstetric and neonatal care. And the ICER, or how many dollars per healthy year, or disability adjusted life year. So this is the $1 per healthy year investments, very cost effective, and this is the less cost effective end of the scale. And we typically see that all the obstetric and neonatal care interventions are less than $250 per healthy year. Very cost-effective interventions, but depending on what threshold you set for starting with antihypertensives and statins, we see that with a 35% risk threshold, it's $74 per healthy year for antihypertensives and statins, and up to $442 with a bit lower risk threshold. And anti-epileptic drugs is at $448. But the best buys are obstetric and neonatal health care. Cost effectiveness analysis are insensitive to the distribution, ignorant to who benefits from the interventions, and it is important to give priority to worst off for fairness reasons. So who are the worst off groups relevant for priority setting in health? Either those having the lowest lifetime health, or the poorest or other disadvantaged groups. We can rank order intervention by severity, for example, lifetime prognostic health loss using healthy adjusted age at death. We typically see that schizophrenia is more severe than Alzheimer. Because you get schizophrenia early in life, it reduces your quality of life for many years. Alzheimer's disease occurs late in life, less severe. So this would favor schizophrenia. Financial risk protection and reducing out-of-pocket payments is important, both to improve access to care and to prevent financial risk for households. Surgery, for example, is a huge financial risk in many places, and we typically see that low and low middle income countries have much higher financial risk associated with surgical care than we see in high income countries. Ethical principles is general, important, but can be difficult to apply when you want to give priority to very concrete services. So then criteria can be more tailor-made and better to use. For example, maximizing health and priority to worst off can be specified with the criteria you see in the green box. Everyone would agree that these are acceptable criteria, but how important they are, people would disagree on. Everyone would agree that selecting interventions according to the gender, sexual orientation, religion, race, social status, education of the benefiting group would be discrimination and unacceptable. Here is the list of unacceptable criteria where both there is disagreement in the literature and among people. For example, productivity or responsibility for health. There are both good arguments for and against selecting services based on productivity or a responsibility for health. Financial risk protection is more difficult to apply when you want to set the priority level of interventions, but an important principle for financing health services.